Welcome to today's presentation on high flow nasal cannula in children, evidence-based review and clinical applications. I'm excited to share this comprehensive overview with you today. This presentation is brought to you by Medaptly, where we're committed to providing high-quality medical education content absolutely free. This is part of our ongoing series of evidence-based presentations designed to keep healthcare professionals updated on the latest clinical practices and research. High flow nasal cannula therapy has become increasingly popular in pediatric respiratory care, particularly for conditions like bronchiolitis. Today, we'll explore the science behind this technology, examine the current evidence, and discuss practical implementation strategies that you can apply in your clinical practice. Today, we'll cover four main parts to give you a complete understanding of high flow nasal cannula therapy. Part one focuses on understanding HFNC, defining what it is, how it works physiologically, and the technical aspects of the equipment. Part two covers clinical applications, when to use HFNC, how to determine appropriate flow rates, and essential monitoring parameters for safe therapy. Part three examines the evidence and outcomes, reviewing current research, comparing HFNC to other therapies like CPAP, and discussing important safety considerations. Part four discusses implementation, step-by-step protocols, real clinical cases, and future research directions. By the end of this presentation, you'll have a solid foundation to confidently implement HFNC therapy in your clinical practice. Now, we'll start with understanding what HFNC really is. Understanding what high-flow nasal cannula therapy actually is and how it developed is essential before diving into clinical details. We'll explore the key features that make HFNC different from conventional oxygen therapy and examine why it's become particularly valuable in pediatric respiratory care. So what exactly is high-flow nasal cannula, or HFNC, as we commonly call it? HFNC is a form of non-invasive respiratory support that delivers a carefully controlled mixture of heated and humidified gas at flow rates much higher than traditional oxygen therapy. Think of it as an enhanced version of the standard nasal cannula that we're all familiar with. Now, here are the key features that make HFNC unique. First, the flow rates are significantly higher, starting at 2 liters per minute and going up to 70 liters per minute, depending on the patient size and clinical indication. The gas is heated to body temperature, exactly 37 degrees Celsius, which is crucial for patient comfort and physiological benefit. It's also humidified to 100% relative humidity, preventing the mucosal drying that we often see with conventional oxygen delivery. HFNC allows us to deliver a precise fraction of inspired oxygen, or FiO2, ranging from room air at 21% all the way up to 100% oxygen when needed. Finally, the system uses wider bore nasal prongs compared to standard nasal cannulas, which helps accommodate these higher flow rates while maintaining patient comfort. This combination of features makes HFNC a powerful tool in our respiratory support arsenal, bridging the gap between simple oxygen therapy and more invasive interventions like CPAP or mechanical ventilation. To understand where high-flow nasal cannula stands today, it's important to look at its historical development and the limitations it was designed to overcome. HFNC was first introduced in neonatal intensive care units as an alternative to CPAP for preterm infants. Initially, its use was quite limited and confined to specialized neonatal settings. However, as clinicians gained experience and confidence with the technology, its application expanded into pediatric units, particularly for managing bronchiolitis in infants and young children. Today, we're seeing growing popularity in adult critical care settings as well. It's worth noting that the clinical adoption of HFNC has actually outpaced the development of robust research evidence, which is something we'll discuss in detail later in this presentation. Before HFNC became available, conventional oxygen therapy had significant limitations that frustrated both clinicians and patients. Flow rates were restricted to just half a liter to 1 liter per minute in neonates and a maximum of 2 liters per minute in older children and adults. These low flow rates were necessary to prevent mucosal drying and discomfort, but they often couldn't meet patients' actual inspiratory flow demands. The inadequate humidification caused mucosal irritation, and perhaps most importantly, conventional oxygen therapy had very limited ability to reduce the work of breathing in patients with respiratory distress. HFNC was developed specifically to address these fundamental limitations. Now that we understand what high flow nasal cannula is and how it developed, let's explore the fascinating science behind how it actually works. In this next section, we'll dive deep into the mechanisms of action that make HFNC such an effective respiratory support tool. Understanding these physiological principles is crucial for optimizing patient care and knowing when and how to use this therapy most effectively. We'll examine the primary respiratory mechanics involved, look at the measurable physiological benefits, and review actual clinical data showing how HFNC impacts patient outcomes. This foundational knowledge will help you make informed decisions about implementing HFNC in your practice. Let's begin by exploring the primary mechanisms that make high-flow nasal cannula therapy so effective. High-flow nasal cannula works through several interconnected mechanisms that work together to improve respiratory function in children. Let's start with the respiratory mechanics. First, HFNC provides washout of nasopharyngeal dead space. This means that the high flow rates literally flush out the upper airway, removing carbon dioxide and increasing the concentration of fresh oxygen that reaches the alveoli. This leads to significantly increased alveolar ventilation. The therapy also reduces inspiratory resistance by meeting or even exceeding the patient's inspiratory flow demands. When a child is struggling to breathe, their inspiratory efforts can be enormous. HFNC provides that flow readily available, reducing the work required. Additionally, HFNC provides what we call a PEEP-like effect, a gentle, distending pressure that helps keep airways open and improves overall airway conductance. Now, looking at the physiological benefits, the heated and humidified gas delivered by HFNC reduces the metabolic demand on the patient. Normally, the body has to warm and humidify inspired air, which requires energy. HFNC does this work for the patient. The system consistently meets inspiratory flow demands, which dramatically reduces the work of breathing. It also improves mucociliary clearance, helping patients clear secretions more effectively, and prevents the mucosal drying and inflammation that we often see with conventional oxygen therapy. These mechanisms work synergistically to provide comprehensive respiratory support that goes far beyond simple oxygen delivery. The physiological benefits we just discussed aren't just theoretical, they can actually be measured and documented in clinical practice. When we look at respiratory function improvements, studies have consistently shown that HFNC reduces diaphragmatic electrical activity. This is a direct measurement of how hard the diaphragm is working. And the reduction tells us that patients are literally working less to breathe. We also see decreased esophageal pressure swings. These pressure measurements serve as a surrogate for pleural pressure and work of breathing. Smaller pressure swings mean the respiratory muscles are under less stress. Perhaps most importantly, HFNC increases end-expiratory lung volume. This means more of the lung stays open at the end of each breath, improving gas exchange efficiency. Studies using electrical impedance tomography have demonstrated improved ventilation, perfusion matching, which optimizes how well oxygen and carbon dioxide are exchanged. The enhanced carbon dioxide clearance is particularly valuable in conditions like bronchiolitis, where CO2 retention can be a significant problem. From a clinical standpoint, these physiological improvements translate into measurable bedside changes. We consistently see decreased respiratory rates in patients on HFNC. Oxygenation metrics improve across the board. And end-tidal CO2 levels typically decrease as ventilation becomes more efficient. Parents and nurses often comment on how much less accessory muscle use they observe, and patients develop a more effective, less labored breathing pattern. These measurable improvements provide objective evidence that HFNC is delivering real clinical benefit. One of the most important aspects of understanding HFNC is how it generates pressure within the respiratory system. Unlike CPAP, which has a controlled pressure relief valve, HFNC creates pressure through a different mechanism entirely. The actual pressure delivered to a patient's airways depends on several critical factors that we need to understand. First is the flow rate itself. There's an approximately linear relationship. Higher flow rates generate greater distending pressure. This is why flow rate selection is so crucial for patient safety and efficacy. Patient size and weight play a major role. Smaller patients, particularly infants, will receive higher pressures at the same flow rate compared to larger children. This is why weight-based dosing protocols are so important. The ratio of cannula size to the patient's nares is another key factor. If the cannula fits too tightly in the nostrils, pressure can build up significantly. We recommend that the cannula outer diameter should be no more than 50% of the nares diameter to allow adequate leak. Interestingly, mouth position matters too. When a patient's mouth is closed, pressures increase substantially because there's less escape route for the gas flow. When the mouth is open, much of the flow escapes, reducing the delivered pressure. This is fundamentally different from CPAP, where a pressure relief valve controls the delivered pressure regardless of these variables. With HFNC, we're relying on natural leak pathways, which makes understanding these factors essential for safe and effective use. Now let's look at actual clinical data showing how much pressure HFNC generates in real patients. This evidence helps us understand what pressures we can expect in clinical practice. The Malay study in 2013 was particularly important because it studied infants with bronchiolitis using flow rates from 1 to 7 liters per minute. They found that when using 2 liters per kilogram per minute, they could consistently generate clinically relevant pharyngeal pressures of 4 centimeters of water or higher. This was a key finding because it showed that HFNC could deliver meaningful distending pressure. Aurora and colleagues studied infants under 12 months using flows from 1 to 8 liters per minute. They demonstrated that beautiful linear relationship I mentioned. As flow rates increased, nasopharyngeal pressure increased predictably. This gave us confidence in titrating flows based on clinical need. A Spence's study looked at a broader age range, from newborns to 12-year-olds, using higher flow rates, with flows of 8 to 12 liters per minute in infants and 20 to 30 liters per minute in older children. They measured an average nasopharyngeal pressure of 4 centimeters of water, with some variation. Rubin's study in 2014 was notable because they used esophageal pressure measurements as a surrogate for pleural pressure. They found that higher baseline pleural pressures correlated with increasing flow rates, providing evidence that HFNC was indeed providing a PEEP-like effect. Finally, Huff and colleagues used electrical impedance tomography to show that 8 liters per minute provided significantly increased end expiratory lung volume compared to 2 liters per minute in bronchiolitis patients. These studies collectively show that HFNC generates clinically meaningful pressures, typically in the 2 to 6 centimeter water range, depending on flow rates and patient factors. High Flow Nasal Cannula works through several key mechanisms that make it effective in pediatric respiratory care. HFNC provides washout of nasopharyngeal dead space, reduces inspiratory resistance, and delivers distending pressure similar to PEEP. The heated and humidified gas reduces metabolic demands and significantly decreases the work of breathing. These combined mechanisms explain the consistent clinical improvements we see with HFNC therapy. This slide illustrates the essential components that constitute a high-flow nasal cannula system. Understanding how these parts function together is key to appreciating the therapy's physiological effect. The process begins with the gas sources. Medical air and oxygen are fed into a blender, which allows for the precise titration of the fraction of inspired oxygen, or 5O2, to meet the patient's specific needs while avoiding unnecessary hyperoxia. From the blender, the gas moves to the flow controller. This device generates the high flow rates that define the therapy, often set to meet or exceed the patient's own peak inspiratory flow demand. This is a fundamental mechanism for reducing the patient's work of breathing. Next, the gas enters the active humidifier, arguably the most critical component for patient tolerance and efficacy. Here, the gas is warmed to physiological body temperature, approximately 37 degrees Celsius, and humidified to nearly 100% relative humidity. This conditioning of the gas is vital. It avoids the patient discomfort and mucosal injury associated with cold, dry air. It improves mucociliary clearance of secretions. It can reduce bronchoconstriction, and it lowers the metabolic energy the patient would otherwise expend warming and humidifying inhaled gas. To preserve this optimal state, the gas is then transported through a heated, insulated circuit. This component is crucial for preventing condensation and ensuring the gas arrives at the patient at the target temperature and humidity. Finally, the fully conditioned gas is delivered to the patient through a specialized wide-bore nasal cannula, which is designed to be more comfortable and handle higher flows than a standard cannula. Together, these components create an integrated system that delivers a comfortable, non-invasive respiratory support with multiple therapeutic benefits. This slide illustrates determining the appropriate flow rate is a critical step in safely and effectively applying HFNC therapy. It's important to recognize from the outset that the literature confirms there are no definitive international guidelines, and the optimal maximal flow for children is not yet known. However, evidence-based clinical practice has led to two primary approaches. The first and most common method for infants and young children is a weight-based approach. Many studies and protocols utilize a starting flow rate of 1 to 2 liters per kilogram per minute for infants. This is often capped at a maximum flow of between 8 and 12 liters per minute, as very few studies have explored flows higher than 10 L/min in this vulnerable population. The second method is an age-based approach, as detailed in the table. This provides practical guidance with a defined starting flow and a maximum limit for different age categories. You can see how the recommended flows increase substantially with the size and age of the child, with studies in older children using flows up to 50 liters per minute. Regardless of the method used, a crucial safety consideration is that high flow rates must be applied with caution, particularly when a child is managed outside of a pediatric intensive care unit where monitoring is most intensive. The goal is always to start within a recognized safe range and titrate based on clinical response. Proper equipment selection and setup are fundamental to the safe and effective delivery of high-flow nasal cannula therapy. The most critical aspect of this process is choosing the correct cannula size. As the diagram clearly illustrates, the guiding principle is that the cross-sectional area of the cannula prongs should not exceed 50% of the patient's nares. This is not simply for comfort. It is a crucial safety mechanism. Leaving this intentional gap ensures that there is an escape route for the gas, which prevents the buildup of excessive and unpredictable airway pressure. Using a cannula that is too large and occludes the nares can increase the risk of barotrauma. The leak around the prongs is a planned and necessary feature of the HFNC system. Beyond sizing, proper setup involves several key steps. The circuit must be pre-warmed before placing it on the patient to ensure the delivery of gas at the target temperature of 37 degrees Celsius from the start. The FiO2 should be titrated to meet the patient's oxygen saturation targets, and the circuit must be monitored and drained of any condensation to maintain effective gas flow. Meticulous attention to these details is essential for maximizing therapeutic benefit while minimizing risk. Now we're moving into the practical heart of our discussion, the clinical applications of high-flow nasal cannula therapy. This is where theory meets practice. We've covered the mechanisms and technical aspects, and now it's time to explore when, why, and how we actually use HFNC in real clinical scenarios. In this section, we'll examine the specific indications for HFNC use, discuss patient selection criteria, and review the evidence for different clinical conditions. We'll also cover essential monitoring protocols and help you identify which patients are most likely to benefit from this therapy. Understanding the clinical applications is crucial for making informed decisions about respiratory support in pediatric patients. Let's explore how HFNC fits into your clinical toolkit. Let's start by examining the primary indications for high-flow nasal cannula use in pediatric patients. HFNC has several well-established indications where the evidence is strongest. Bronchiolitis leads this list with the most robust research supporting its use in this condition. We also see excellent results in moderate respiratory distress, hypoxemic respiratory failure, and as post-extubation support. Many institutions now use HFNC as an effective step-down therapy from CPAP or mechanical ventilation. The applications for HFNC continue to expand as we gain more experience with the technology. We're seeing promising results in pneumonia cases, asthma exacerbations, and even obstructive sleep apnea. Postoperative respiratory support is another growing area, and HFNC is proving valuable for transporting patients with respiratory compromise. What's particularly exciting is how HFNC bridges the gap between simple oxygen therapy and more invasive respiratory support. It offers us a middle ground that many patients tolerate much better than traditional alternatives. The key is understanding which patients are most likely to benefit from this therapy versus those who need immediate escalation to more intensive support. While HFNC has many valuable applications, it's equally important to understand when we should not use this therapy or when we need to proceed with extra caution. Sure, several absolute contraindications where HFNC is simply not appropriate. Patients with severe respiratory distress who need immediate intubation should not be delayed with HFNC trials. In untrained pneumothorax is a clear contraindication, as is significant upper airway obstruction. We also avoid HFNC in patients with recent nasal surgery, base of skull fractures, or those who cannot protect their airway. Then we have situations where we can use HFNC, but we need to be much more vigilant. Congenital heart disease patients have shown higher failure rates in studies, with some reporting up to 50% treatment failure. Patients with intra-abdominal pathology need careful monitoring due to the risk of gastric distension. Very premature infants outside the NICU setting, severe maxillofacial trauma, and severe coagulopathy all require additional caution. The key message here is that HFNC is not a one-size-fits-all solution. Proper patient selection is crucial for both safety and effectiveness. When in doubt, it's always better to err on the side of caution and consider more established respiratory support methods. Remember, recognizing these contraindications early can prevent complications and ensure patients receive the most appropriate care from the start. Let's focus specifically on bronchiolitis, which is truly the flagship indication for high-flow nasal cannula therapy in pediatric patients. The evidence for HFNC in bronchiolitis is more robust than for any other pediatric condition. In fact, 13 of the 26 major studies we reviewed focused exclusively on bronchiolitis patients. This concentrated research has given us valuable insights into how HFNC works in this population. The clinical benefits we see are quite impressive. Studies consistently show reduced respiratory rate and decreased work of breathing. Parents and nurses often comment on how much more comfortable these children appear. We also see improved oxygenation with higher sustained oxygen saturations. And perhaps most importantly, observational studies suggest we're reducing intubation rates. From a practical standpoint, timing matters. Early initiation of HFNC appears to be more effective than waiting until children are severely distressed. The beauty of HFNC is that we typically know within 60 to 90 minutes whether it's going to work. Flow rates of 2 liters per kilogram per minute, up to a maximum of 10 liters per minute, are the most commonly used and well-studied ranges. What's particularly valuable is that HFNC has proven safe for use in general pediatric wards with appropriate monitoring, not just intensive care units. This makes it accessible to more patients and can potentially reduce PICU admissions. The key is knowing when to wean. Most experts recommend considering weaning when patients have been clinically stable for 4 to 6 hours. Effective monitoring is absolutely critical when using high-flow nasal cannula therapy. Let me walk you through the essential parameters that every clinician needs to assess. First, we focus on respiratory parameters. This includes monitoring respiratory rate, assessing work of breathing, tracking oxygen saturation, and noting FiO2 requirements. These are your primary indicators of how well the therapy is working. Next, we monitor cardiovascular parameters. Heart rate, blood pressure, and overall perfusion give us important clues about the patient's response to therapy. Often, we'll see heart rates normalize as work of breathing decreases. Clinical assessment remains fundamental. We need to evaluate the level of distress, listen to air entry, watch for chest retractions, and ensure nasal patency and patient comfort. Remember, HFNC should make patients more comfortable, not more distressed. Don't forget the technical aspects. We must verify the flow rate is appropriate, check cannula positioning, ensure proper humidification, and maintain circuit patency. Equipment issues can quickly undermine therapy effectiveness. Finally, stay alert for concerning parameters, blood gas values when available, persistent tachypnea despite therapy, and increasing oxygen requirements are all red flags. Here's the key point. Monitoring frequency should increase in patients with concerning features during initial therapy or after any flow rate changes. Most experts recommend continuous cardiorespiratory monitoring for all patients on HFNC. This isn't passive therapy. It requires active, ongoing assessment to ensure both safety and effectiveness. One of the most critical skills in HFNC management is identifying patients who aren't responding to therapy. Early recognition can be the difference between successful treatment and dangerous delays in escalating care. Let's start with the early indicators of treatment failure. If you don't see improvement in respiratory rate within 60 to 90 minutes, that's a significant red flag. Persistent or worsening work of breathing despite adequate HFNC settings is another clear warning sign. We should also be concerned if the heart rate fails to normalize, if oxygen requirements keep increasing, or if we see initial hypercapnia with a venous PCO2 above 50 millimeters of mercury, or respiratory acidosis with a venous pH below 7.3. Now, certain patient factors put children at higher risk for HFNC failure. Younger age, particularly infants under 6 months, is associated with higher failure rates. Higher initial respiratory distress scores also predict poor outcomes. Here's a sobering statistic. Congenital heart disease patients have up to a 50% failure rate in some studies. Premature infants, those with respiratory failure from non-bronchiolitis causes, and children experiencing apnea episodes before or during therapy are all at increased risk. The key message here is simple but crucial. Don't wait too long. If a patient isn't showing clear signs of improvement within the first 90 minutes, seriously consider escalating to CPAP or preparing for intubation. Remember, HFNC is meant to help patients get better, not just maintain a tenuous status quo. Trust your clinical judgment. If something doesn't feel right, it probably isn't. Now we move into one of the most critical aspects of our discussion, the clinical evidence supporting high flow nasal cannula therapy in children. And this is where we'll examine what the research actually tells us about HFNC effectiveness. We'll look at the quality of studies available, analyze key clinical outcomes, and honestly assess both the strengths and limitations of the current evidence base. Understanding the evidence is crucial for making informed clinical decisions about when and how to use HFNC in your practice. Let's explore what science tells us about this increasingly popular respiratory support modality. Let's be honest about the current state of evidence for high flow nasal cannula in pediatric patients. While HFNC has gained widespread popularity, the quality of supporting evidence presents some important considerations. Currently, we have limited high-quality evidence from randomized controlled trials, specifically in children beyond the neonatal period. Most of our knowledge comes from observational studies with relatively small sample sizes. This doesn't mean the therapy is ineffective, but it does mean we need to interpret the data carefully. The strongest evidence we have is in bronchiolitis populations where multiple studies have shown consistent benefits. However, there's significant variability in outcome measures between different studies, making direct comparisons challenging. One particularly notable gap is that we have only one randomized controlled trial comparing HFNC directly to CPAP in children beyond the neonatal period. Additionally, there is a lack of standardized protocols for flow rates and weaning procedures across institutions. This evidence landscape tells us that while FFNC shows promise and has demonstrated safety in clinical practice, we still need more robust research to fully establish its role in pediatric respiratory care. This is why evidence-based implementation and careful monitoring remain so important. Now let's examine the key clinical outcomes that researchers have studied with high-flow nasal cannula therapy. This table summarizes what we actually know from the available literature. Studying with respiratory parameters, we have moderate quality evidence showing consistent improvements across multiple studies. Patients on HFNC demonstrate reduced respiratory rates, decreased work of breathing, improved oxygen saturation, and better end-tidal carbon dioxide levels. This is probably our most reliable finding. When it comes to PICU admissions, the evidence is less robust. One case control study showed a dramatic 4-fold reduction in PICU admissions, which sounds impressive. However, other studies have been inconclusive, so we rate this as low-quality evidence. Length of stay results are mixed. Some studies show reductions, while others show no difference at all. This variability makes it difficult to draw firm conclusions about HFNC's impact on hospital stay duration. Intubation rates present an interesting finding. Observational studies suggest that HFNC may reduce the need for intubation, but again, this is low-quality evidence primarily from before and after studies rather than controlled trials. The comparison with CPAP shows limited evidence suggesting similar efficacy for moderate respiratory distress. This is important because it suggests HFNC might be a viable alternative to CPAP in certain situations. Finally, patient comfort stands out as one of our more solid findings. Multiple studies consistently show improved comfort compared to other oxygen delivery methods, with moderate quality evidence supporting this benefit. The key takeaway here is that while HFNC shows promise across multiple outcomes, much of our evidence base needs strengthening through larger, well-designed studies. Let's dive into one of the most clinically relevant comparisons in pediatric respiratory care, high-flow nasal cannula versus CPAP. Understanding when to choose one over the other is crucial for optimal patient management. First, let's look at what these two modalities have in common. Both HFNC and CPAP provide continuous distending pressure to the airways, which helps maintain lung recruitment and reduces work of breathing. The landmark randomized control trial by Chisti and colleagues found no significant difference between HFNC and CPAP for children with severe pneumonia. Observational studies have also shown similar rates of escalation to higher levels of respiratory support, suggesting comparable effectiveness for moderate respiratory distress. However, there are some important differences to consider. CPAP provides more consistent and predictable pressure delivery because it has integrated pressure control mechanisms. This makes CPAP potentially superior for patients with severe respiratory distress who need precise pressure support. On the other hand, HFNC offers significant advantages in patient comfort and tolerance. Patients can speak, eat, and clear secretions more easily with HFNC. Healthcare providers consistently report that HFNC is easier to administer and manage compared to CPAP systems. An important safety consideration is that HFNC is associated with lower rates of nasal trauma compared to CPAP, which can cause pressure sores and skin breakdown with prolonged use. The choice between HFNC and CPAP often comes down to patient severity, comfort considerations, and institutional capabilities. Both have important roles in our respiratory support toolkit. One of the most significant advantages of high-flow nasal cannula that often gets overlooked in clinical discussions is patient comfort and tolerance. This isn't just a nice-to-have feature, it's a clinically important benefit that can impact treatment success. And evidence consistently shows improved comfort scores when comparing HFNC to other oxygen delivery methods. This isn't surprising when you consider the practical differences. With HFNC, children can continue normal activities like feeding and speaking, which is particularly important for maintaining nutrition and family bonding during illness. From a safety perspective, HFNC demonstrates lower rates of nasal trauma compared to CPAP. Anyone who has worked with CPAP knows that pressure sores and skin breakdown can be significant problems, especially with prolonged use. HFNC's gentler interface reduces these complications. Parents consistently report better satisfaction with HFNC because it's easier to interact with their child. The child's face isn't covered by a mask, making feeding, comforting, and communication much more natural. This psychological benefit shouldn't be underestimated, can significantly impact the overall hospital experience for families. Healthcare providers also appreciate HFNC because it generates less noise than CPAP systems, creating a calmer environment. The ease of nursing care and administration is another practical advantage that contributes to overall treatment success. When we consider that patient compliance and comfort directly impact treatment effectiveness, these comfort advantages become clinically significant benefits rather than just quality of life improvements. Now let's turn our attention to a critical aspect of high-flow nasal cannula therapy that every clinician must understand: safety considerations. While HFNC has proven to be a valuable tool in pediatric respiratory care, like any medical intervention, it's not without risks. Understanding these potential complications and how to prevent them is essential for safe clinical practice. In this section, we'll examine the reported adverse events from the literature, discuss risk factors that increase the likelihood of complications, and most importantly, review evidence-based safety recommendations that will help you implement HFNC therapy confidently and safely in your patients. Patient safety must always be our top priority. So let's explore what the evidence tells us about the safety profile of high-flow nasal cannula therapy. Let's examine the safety profile of high-flow nasal cannula therapy based on the available literature and clinical experience. The good news is that serious adverse events with HFNC are quite rare. However, we do need to be aware of several important complications that have been reported. The most significant concern is pneumothorax. With only 4 cases documented in the literature, these occurred in patients ranging from a 2-month-old infant with bronchiolitis to a 16-year-old with cerebral palsy. What's notable is that some of these cases involved higher flow rates, which reinforces the importance of careful flow rate selection. Other reported complications include occasional abdominal distension and nasal mucosal injury, which can lead to nosebleeds. These are generally less serious, but still require attention. So, now, how do we minimize these risks? First, appropriate patient selection is crucial. We need to avoid using HFNC in patients who require immediate intubation. Second, exercise particular caution with flow rates above 10 liters per minute when you're outside the PICU setting. Close monitoring during initiation is essential, along with proper cannula sizing. Remember, the prong diameter should never exceed 50% of the nostril diameter. Finally, having clear escalation protocols and regularly assessing the nasal mucosa will help you catch potential problems early. With these safety measures in place, HFNC remains a very safe and effective respiratory support option for children. Now that we've covered the evidence and safety considerations for high-flow nasal cannula therapy, it's time to translate this knowledge into practical, actionable clinical protocols. Having effective protocols is absolutely essential for successful pediatric HFNC implementation. Without standardized approaches, we risk inconsistent care, missed opportunities for early intervention, and potentially unsafe practices. In this section, we'll walk through evidence-based protocols that you can adapt for your own clinical setting. We'll cover everything from initial patient assessment and therapy initiation through monitoring parameters to weaning strategies and escalation pathways. These protocols are designed to help you make confident, systematic decisions about when to start HFNC, how to optimize therapy for each patient, and most importantly, when to recognize that a patient needs escalation to a higher level of respiratory support. Let's dive into the practical aspects of implementing high-flow nasal cannula therapy safely and effectively in your clinical practice. Let's walk through the essential steps for safely initiating high-flow nasal cannula therapy in your patients. Step 1 is thorough assessment. Before starting HFNC, carefully evaluate your patient's respiratory status and confirm that they have an appropriate indication for this therapy. Remember, HFNC works best for moderate respiratory distress, not severe cases that need immediate intubation. Step 2 involves proper setup. Select the right cannula size. This is crucial for both comfort and effectiveness. The prong diameter should be no more than 50% of the nostril diameter. Don't forget to pre-warm your circuit with the water chamber, as this ensures optimal humidification from the start. Step 3 is initiation. Start your flow rate based on age or weight-appropriate guidelines. For most infants and young children, this means 2 liters per kilogram per minute, up to your predetermined maximum. Step 4 focuses on oxygen titration. Set your FiO2 to maintain target oxygen saturations between 92 and 97% for most conditions. You can adjust this based on your specific patient population and institutional guidelines. Step 5 emphasizes close monitoring. During the initial phase, assess your patient every 15 to 30 minutes. This is when you'll see the most dramatic changes and need to make quick decisions about therapy adjustments. Remember, continuous cardiorespiratory monitoring is essential, especially during initiation. This systematic approach will help ensure safe and effective HFNC therapy for your patient. Here's a practical algorithm that will guide your decision-making when patients are on high-flow nasal cannula therapy. Once you have a patient established on HFNC for respiratory distress, the critical assessment point comes at 60 to 90 minutes. This is when you need to ask yourself, am I seeing improvement in the respiratory parameters? If the answer is yes, if you're seeing decreased respiratory rate, reduced work of breathing, improved oxygen saturations, and overall clinical improvement, then continue with HFNC and monitor your patient every 1 to 4 hours based on their clinical status. However, if you're not seeing improvement, you need to look for concerning features. These red flags include persistent tachypnea, increased work of breathing, and rise in oxygen requirements. These are warning signs that HFNC therapy may not be sufficient for your patient. When you identify these concerning features, it's time to escalate care. This means transitioning to CPAP, BiPAP, or potentially intubation, depending on the severity of the patient's condition and your clinical assessment. The key to this algorithm is timing. Don't wait too long to make these critical decisions. That 60 to 90-minute window gives you enough time to see if HFNC will work, but prevents you from delaying necessary escalation of care. Remember, recognizing HFNC failure early and acting promptly is just as important as knowing when to start the therapy in the first place. Now let's discuss when and how to safely wean patients from high-flow nasal cannula therapy. Knowing when to start weaning is just as important as knowing when to initiate HFNC. The first step is assessing readiness. Your patient should be clinically stable for 4 to 6 hours with a normalized respiratory rate, minimal work of breathing, and an FiO2 requirement of 40% or less. These criteria ensure your patient is truly ready for the weaning process. Step 2 focuses on FiO2 weaning first. Before you touch the flow rate, reduce the FiO2 to between 21 and 30% while maintaining your target oxygen saturations. This approach allows you to assess how well your patient handles reduced oxygen support before decreasing the flow. Step 3 involves gradual flow reduction. Decrease the flow by 1 to 2 liters per minute or by 0.5 liters per kilogram per minute every 2 to 4 hours as tolerated. This gradual approach prevents sudden changes that might stress your patient's respiratory system. Step 4 is the final transition. Continue weaning down to your minimum flow, typically 2 to 4 liters per minute, before switching to low-flow nasal cannula or room air. Here's a crucial safety tip. If your patient shows any signs of deterioration during weaning, don't hesitate to return to the previous settings that maintain stability. It's always better to take a step back than to push through and compromise patient safety. Successful weaning requires patience and careful observation, but following this systematic approach will help ensure safe transitions for your patients. Let me share a real-world clinical case that beautifully illustrates the practical application of high-flow nasal cannula therapy. Meet our patient, a 9-month-old, previously healthy male who presented with a classic bronchiolitis picture. He had been sick for 3 days with cough, runny nose, and progressively increasing work of breathing. His parents were concerned because he was feeding poorly and seemed to be struggling to breathe. On arrival, his vital signs told the story: heart rate of 165, respiratory rate of 68, and oxygen saturation of only 88% on room air. At 8.5 kilograms, he was a typical bronchiolitis patient, but clearly in respiratory distress. Initially, we tried the standard approach, low-flow oxygen at 2 liters per minute via nasal cannula. While his oxygen saturations improved to the low 90s, he continued to have significant subcostal retractions, and his respiratory rate remained elevated between 58 and 65 breaths per minute. This told us that conventional oxygen wasn't addressing his underlying work of breathing. This is where HFNC made the difference. We transitioned him to high flow nasal cannula at 2 liters per kilogram per minute, which worked out to 17 liters per minute with an FiO2 of 40%. The response was remarkable. Within just 60 minutes, his respiratory rate dropped to 45, his oxygen saturation improved to 96%, and most importantly, his retractions significantly decreased. By 36 hours, he was stable enough to begin weaning the flow down to 12 liters per minute. The outcome speaks for itself. He successfully transitioned to low-flow oxygen therapy by day 3 and was discharged home on day 4. This case perfectly demonstrates how HFNC can bridge the gap between conventional oxygen therapy and more invasive respiratory support, potentially avoiding PICU admission and improving patient comfort. As we look toward the future of high-flow nasal cannula therapy, it's important to acknowledge that while we've made significant progress, there are still important gaps in our knowledge that need to be addressed. Let's start with the key research gaps that remain. First and foremost, we need more high-quality randomized controlled trials comparing HFNC to other respiratory support modalities. Most of our current evidence comes from observational studies, which, while valuable, don't provide the level of evidence we need for definitive clinical guidelines. We also need better guidance on optimal flow rates for different age groups. Currently, there's significant variation in practice, and we need standardized protocols for both initiation and weaning. Additionally, developing reliable predictors of HFNC success and failure would help us make better treatment decisions up front. Cost-effectiveness studies are also crucial, especially as healthcare systems worldwide face increasing financial pressures. We need to understand not just whether HFNC works, but whether it provides good value in various clinical settings. The good news is that several important studies are currently underway. The PARIS study, that's the Pediatric Acute Respiratory Intervention Study, is a large randomized controlled trial specifically examining HFNC in bronchiolitis. This could provide the high-quality evidence we've been waiting for. Researchers are also investigating HFNC for respiratory support during patient transport, exploring its use in conditions beyond bronchiolitis, and comparing early versus rescue therapy approaches. There's even work being done on implementation in resource-limited settings, which could expand access to this technology globally. These ongoing studies will help us refine our understanding of when, how, and for whom HFNC therapy works best, ultimately leading to better outcomes for our pediatric patients. As we near the end of our presentation, I'd like to share a particularly insightful quote that perfectly captures the current state of high-flow nasal cannula therapy in pediatric medicine. This comes from Mickelson and colleagues in their comprehensive 2016 literature review, and I think it beautifully summarizes the balanced approach we should take with this technology. They wrote, "Until more evidence from randomized studies is available, HFNC may be used as a supplementary form of respiratory support in children, but with a critical approach regarding effect and safety, particularly when operated outside of a pediatric intensive care unit." This quote encapsulates everything we've discussed today. Yes, HFNC is a valuable tool with demonstrated benefits, particularly in bronchiolitis. Yes, it's generally safe and well tolerated by patients, but we must remain thoughtful and evidence-based in our approach. The key word here is supplementary. HFNC isn't meant to replace good clinical judgment or other established therapies. It's meant to enhance our toolkit. The emphasis on a critical approach reminds us to continuously evaluate each patient's response and be ready to escalate care when needed. And that final point about being particularly cautious outside the PICU setting is crucial. It reminds us that while HFNC can be used safely in general pediatric wards, it requires appropriate monitoring, clear protocols, and staff training. This measured, evidence-based perspective should guide our clinical practice as we implement HFNC therapy in our own settings. As we conclude today's presentation, let's consolidate the key takeaways that will guide your clinical practice with high-flow nasal cannula therapy. Toward an evidence perspective, we've learned that HFNC is indeed a safe and well-tolerated respiratory support method. It works through multiple physiological mechanisms, from nasopharyngeal dead space washout to providing distending pressure. While most of our evidence comes from observational studies, the strongest data supports its use in bronchiolitis, where it shows similar effectiveness to CPAP for moderate respiratory distress. When it comes to clinical application, remember that flow rates typically follow the 2 liters per kilogram per minute rule, up to safe maximums based on age and setting. The critical monitoring window is those first 60 to 90 minutes. This is when you'll know if HFNC will work for your patient. Early identification of non-responders is absolutely crucial, and you must have clear escalation protocols in place. Don't underestimate one of HFNC's greatest advantages: patient comfort and tolerance, which often makes the difference in successful therapy. For successful implementation, develop standardized protocols for your institution. Train your staff thoroughly on proper setup and monitoring techniques. Regularly assess the efficacy of your HFNC program and apply evidence-based weaning strategies. And remember, maintain caution with higher flow rates when you're working outside the PICU environment. HFNC represents a valuable addition to our respiratory support toolkit. But like any tool, its success depends on proper understanding, careful application, and continuous evaluation of outcomes. With these principles in mind, you'll be well equipped to provide safe and effective HFNC therapy to your pediatric patients. Thank you for joining us today for this comprehensive overview of high-flow nasal cannula therapy in children. I hope this presentation has provided you with valuable insights and practical tools that you can apply in your clinical practice. So we've covered a lot of ground today, from the fundamental mechanisms of HFNC to evidence-based protocols for safe implementation. The key message I want you to take away is that while HFNC is a powerful tool in pediatric respiratory care, its success depends on thoughtful application, careful monitoring, and evidence-based decision-making.